Good afternoon, everyone. Uh, Dr. Sainath Pawar sir doesn't need any introduction. He is a practicing pediatric pulmonologist from Kolhapur and our own president. So I welcome you, sir.
Yeah,
Kindly proceed for
thank
the
you,
talk.
Amar. So today we are going to discuss bronchoscopy. Let's dive in the lungs. Oi, अरे बाप रे. So introduction of the bronchoscopy. As all of us now know that Rick. Okay. So what is bronchoscopy? So we are talking mainly about flexible bronchoscopy. So it is a virtual cruise through the tracheobronchial tree. Flexible bronchoscopy has both diagnostic as well as therapeutic uses. What is the advantage? That it visualize the upper lobe of mainly right upper lobe. Mainly right upper lobe, it is difficult to visualize by rigid scopes. Explore up to 4th or 5th order bronchus. Visualize the dynamics, that is Malaysia part of the bronchus and trachea can be visualized through only flexible bronchoscopy. Specimen collection by bronchoalveolar lavage can be done. So now we will discuss short cases only and we'll go little fast. 9 months old female child, she has got recurrent cough, wheezing, vomiting after feeds. She was treated as gastroesophageal reflux, she was treated as Valerie also. But she required 3 admission for pneumonia and it was for different sites. So definitely by definition also it is a recurrent pneumonia. So we had done, so why baby is getting recurrent pneumonia? So we did a bronchoscopy and here we can see there is this is carina, this is right bronchus, this is left bronchus and you can see one hole here. So this is a tracheobronchial teofistula. So this is a this H fistula type. So it is around 4 to 6% of teofistula are H type. So that was the cause of recurrent pneumonia. So second patient who was 1-year-old child admitted to the peripheral hospital. Baby was having severe respiratory distress, bronchospasm, circulatory shock. Baby was having convulsion and unconsciousness. So baby was so bad that baby was immediately intubated and taken on ventilation. She was ventilated, but on venti was also baby was not doing very well. So there is no significant previous history like wheezing in the past. There was no family history also. On examination there was severe bronchospasm and it has required given all the drugs like Baxel, hydrocortisone, even ketamine was also tried, but somehow it was not responding. Relatives were not giving any history. X-ray was also little confusing. Like this, there is a, you can see that the left side is getting collapsed. There is some haziness also seen in the right side. Then second X-ray after few hours, it was complete collapse. Then right upper lobe pneumonia was collapse or pneumonia was noted. So they referred patient for sort of bronchopneumonia. So we asked them for any history of foreign body ingestion, but they did not give. There was no history of any allergy asthma in the family. A patient was in bad condition. He was having severe respiratory distress. Air entry was reduced on the left side. There was only one confusing thing was there was history of tuberculosis in the family. But immediately when patient came, we did a bronchoscopy and we could see, you can see here that is a foreign body which was, you can see the foreign body which is actually it is in the trachea and it is blocking both the right and left bronchus. So that's why it was means he was having so bad signs and symptoms because there was no space to for aeration. And one thing in this patient was there was a pig bronchus in this patient. Pig bronchus means the right upper lobe bronchus was originating from trachea only, and that foreign body was blocking that also. That's the reason for the right upper lobe pneumonia or whatever collapse consolidation. So what is the message or what should we think of? The persistent cough plus minus wheeze not responding to treatment, we should think of foreign body. Central foreign body like this patient, they are an emergency thing and it can be fatal if not removed timely. Foreign bodies is suspected if a normal child present with sudden respiratory symptoms. Normal X-ray does not rule out foreign body. Any collapse of specific lobe, then we have to look for foreign body, or it may be sometimes mucus plug. So whenever there is a intranumular obstruction, we should prefer bronchoscopy because it will be diagnostic also, and maybe if it is not a foreign body, then we can give a bronchoalveolar lavage. If it is mucus plug, the bronchoalveolar lavage itself will be therapeutic only. So intraluminal obstruction, we should prefer the bronchoscopy, and extraluminal we should go for CT scan. So what is the common age of bronchoscopy? It is said 1 to 5 years, but practically almost most of the cases are below 3 years. 1 to 2 years is again more common age. More than 50% patient will not give any history of foreign body injection. So that is important, that sometimes we are not able to elicit that history. So sometimes we may get surprises also. So this is a next case, that is 3.5 years old male child with history of persistent cough, recurrent fever for last 2 months. He was having intermittent vomiting, anorexia. On examination, he was pale, malnourished. There was on chest examination, there was crepes, no other specific localizing sign. Surprisingly, most of the investigation like CBC was normal, TT was also done negative. X-ray test has shown left upper lobe patch, which is persistence is almost 1.5 to 2 months. GL4FB done thrice, which was negative. So overall, the look was like it was a tuberculosis. But nowadays we do not, if we do not get microbiological diagnosis, generally we do not rush to start AKT. So due to strong suspicion of COX, before starting empirical AKT, we decided to go ahead with bronchoscopy. So here you can see, this is white thing. These are granulation tissues along with tubercles. So this is we can say that it is an endobronchial tuberculosis with tubercles and granulation tissues. So, so this was then, and we sent a ball also, which was CBNet positive. So, what is the importance of this bronchoscopy? Or whenever there is an endobronchial tuberculosis, we need to give steroids to these patients. So we should diagnose that endobronchial tuberculosis. Unless and until we do a bronchoscopy, it is not possible to see these granulation tissues and tubercles. So, and one thing I would like to add here, that now NTP has also taken this concept of bronchoscopy, and now in Kolhapur we can do a free bronchoscopy if we are strongly suspecting tuberculosis. We already, Nanodekar sir's patient, we already done it. So if you are strongly suspecting, only thing we have to convince this to the TB officer, district TB officer, and we'll able to do it free. Means government will pay to me, and we can, for patient it will be free. So this patient, CBNet was positive, AKT was started. So what is the discussion? Like specimens like gastric lavage, induced sputums are definitely we have to do, but sometimes if they are negative, do not rush to start empirical AKT. Go for bronchoscopy. As I said, now we can do it free also. So, and endobronchial tuberculosis can be diagnosed on bronchoscopy. So, whenever there is endobronchial tuberculosis, we need to give steroids. So, next case is 5 years old male child with history of repeated LRTI every 2 to 3 months interval. Almost he was admitted more than 15 times, sir's patient, Uday Patil sir's patient. He was, various times he was admitted with cough, cold, fever, like LRTI picture, and breathlessness, wheezing. In between also, episodes also, he was symptomatic. So he was started on MDI, but no response. So no family history of allergy, asthma or something. So in this patient, what we could found. So here, this is a trachea actually, and we can see the actually trachea should be oval, but this is a slit-like trachea, and continuous. We have seen, means this is, I am showing one video, but we have seen it for various time. So it was a continuous slit-like trachea. So that means it was a diagnosis was tracheomalacia. So if the patient is present with recurrent wheeze and beta agonist is not showing a desired therapeutic response, then we should think of tracheobronchomalacia. Or sometimes if the patient is behaving like under 5 wheezer with not responding to inhalers, again we should think of tracheomalacia. So accordingly we can go ahead. So what is this tracheomalacia? This is a normal oval trachea, and this is a tracheomalacia. So it is a slit-like, so it is difficult to pull out the secretions, so there will be pulling of secretions, and he will get repeated respiratory symptoms. So what is the what we can do in this patient? So generally beta agonist will deteriorate this patient. So drug of choice in this patient for nebulization is ipratropium bromide. It appears to be beneficial in such conditions. And if it is severe, then they may require some interventions also. So 11 months old girl, next case is 11 months old girl born of non-consanguineous marriage, complaints of fever, cough, respiratory distress since last 8 days. She was toxic, respiratory distress, wheezing was positive, Krebs was positive. Last, again, as there was discussion in last panel discussion, so 2 previous admissions for similar complaints at around 4 to 6 months. Previous admission, she had fever, wet cough, tachypnea, then poor weight gain. Again, on inquiry, they give, deep inquiry, they give query history of oily stool. So X-ray was like, there is some reticulonodular pattern, but not any clear-cut pneumonia in this X-ray. Then we did a ABG, which was showing a hyponatremia, hypochloremia, alkalosis. Stool fat was done after giving butter to the baby. Then it was positive. So almost everything is getting clear. What I wanted to show here that what we did a bronchoscopy to actually we wanted to look for the organism. And we can see here that almost the lungs are filled with pus only. Almost all the lungs were full of, it was filled with pus. You can see everywhere there is a pus. So there was no anatomical abnormality, but we collected a ball, we did a therapeutic lavage also, and this grown Pseudomonas aeruginosa. As we discussed, it is a hallmark of cystic fibrosis. Then we further worked up this patient. Sweat chloride was also on, actually it was borderline. 80 is, above 80 is abnormal, it was 79. So we did a genetic study which turned out to be cystic fibrosis. So this patient was started on airway clearance therapy. So here I wanted to discuss that depending on organism also we should think of some diseases. Like if there is a staphylococcus, it may be it may be related to pyoderma, measles. If we are getting pneumocystis, we should rule out HIV. In cystic fibrosis, we will get Pseudomonas, and in infants, we will get staphylococcus. In malnourished patient, we may get gram-negative organism on Staphylococcus aureus. Then aspergillus may be seen in neutropenia. If you are seeing anaerobus, we should think of aspiration. So whenever there is a red alert, work up this patient. If there is a recurrent disease, if there is a family history, if there is a systemic involvement, if there is associated comorbidities or typical finding, we should investigate those patients. So now this is a Viraj 4 years old patient. So you just sound. One second. So you can see this patient, 4 years old child with cough, cold, fever, and this type of sounds, stridor, respiratory distress, wheezing was also there. And he had similar episode like croup-like illness in past. Few times it has happened similarly. Whenever he used to get some viral infection, he used to get like this. So symptom, we admitted this patient was treated. He settled after starting antibiotics, steroids, and nebulization was everything. The patient was absolutely normal. Then we were not convinced why he is getting repeated symptoms. So we did a bronchoscopy, and here we can see. You can see here that there is a laryngeal cyst. There is something coming out of here. You can see below vocal cords. So this is a laryngeal cyst. And because of whenever he used to get some viral infection, there must be inflammation, swelling, and it used to obstruct the vocal, means glottis, and then he used to get stridor. And if you treat them, then in between episode he would be fine. So whenever there is a like croup-like symptoms repeatedly, so then we have to rule out the structural anomalies. When it is, we can say recurrent, that if it is more than 2 episodes in 1 month, more than 3 episodes in 1 year, and if the age group is abnormal, like less than 6 months or more than 6 years. And if there is a history of intubation, then we should investigate this patient for any stridor-like thing. This is a second baby, 3 months old baby with stridor and failure to thrive. There was no weight gain for this baby, and we are seeing the stridor. It is so whenever there is a failure to thrive along with stridor, then we should investigate this patient, and you can see there is a epiglottic cyst here, the round thing here. You can this is epiglottis, and there is a cyst which is pressing that epiglottis, which is causing the stridor. So it is also called as bilocular cyst. This is again 4 months old baby. 4 months old baby with repeated stridor, wheezing, and admitted 2 times. Dr. Aunkar sir's patient from Karad. So in between episode was baby was having intermittent stridor. So sir said, why is getting so many times admitted? Let us do a bronchoscopy, and we did a bronchoscopy on this patient. So you can see here we are seeing cords, and below cord there is a bulging seen. So this is a subglottic cyst. He was operated, and it turned out to be a subglottic hemangioma. So this patient, all the lesions near the vocal cords, they require a tracheostomy to operate. Initially they will do a tracheostomy, then they will operate, and they will keep that tracheostomy for few days, and then they will remove. Again this baby, just see the baby. So again stridor, it was thought that this baby is having laryngomalacia, but it was present on the day 1. So again day 1 stridor is generally not common. Sorry. So here you can see you can see this vocal cords. So if you can note down that this side is not moving. This is a arytenoid cartilage. This side it is moving, and this side it is not moving. So this is a vocal cord palsy. This is unilateral vocal cord palsy. Generally does not require any treatment, but the cause of stridor was not laryngomalacia. This was the vocal cord palsy. So message: all stridors are not laryngomalacia. So investigate the patient. If the stridor is at birth, there is a failure to thrive, or there is a cyanotic or choking episodes. Again, this is a newborn baby with, I have shared this patient on group. So there was no voice actually. The father said silencer बसवलाय काय. So बाळाच्या ह्याच्यात silencer बसवलाय. So in this patient, you can see there is a web here. This is vocal cords, almost blocking 40 to 50% of the glottis. You can see here. I will show you another patient who is recently we have seen. So you can see there, this is a thick web, very small opening of glottis. So this patient had stridor with respiratory distress. He had only aphonia with intermittent stridor, but baby was stable. This baby was unstable. So now only spotters I will show you. So you can see what is this? It is in the left bronchus actually. We are in left bronchus. Can you anything? This? It is a tooth. Daat hai to daat. So convulsing patient, because of convulsions, he had some actually. I think the relatives must have put something as he convulsing, and then this tooth it went into left side. And this patient, just you see, this is a vocal cord, and you can see here, this is a chicken bone. Nadi म्हणतो तसं. In between the two larynx, you can see now you can see. त्याचा तुकडा आहे तो. So what are the indications for bronchoscopy? Let's discuss in very short. Bronchoscopy assesses the airway both anatomically and dynamically. Stridor since birth, as we discussed, if there is a cyanosis, choking episode, failure to thrive, and on day 1. So what are the reasons? That supraglottic cyst, most of the cases we have already seen, supraglottic cyst, web, sometimes cleft, we have we have seen 2 patients of cleft actually, vocal cord paralysis, then subglottic cyst, laryngeal papilloma, subglottic stenosis. Because of sometime intubation also we can get. Any persistent or recurrent pneumonia, we should scope the patient. Persistent hoarseness of voice, aphonia, as we have seen in our patient. Persistent X-ray patch on X-ray, not responding to treatment. Difficulty in weaning from ventilator, especially if the small babies we are not able to wean off from ventilator. We are failing the extubation. Maybe there may be some micromucus plugs which can be cleared with bronchoscopy and therapeutic lavage. And we have done it for many babies actually. Recurrent choking episodes, apnea in neonatal age. It may be, we have seen 2 patients of laryngeal clefts with similar presentations. Then endobronchial tuberculosis, as we have seen in our patient, persistent wheeze, not responding to inhalers. We may think of like tracheomalacia or any other anomalies can be seen. If you want to do BAL, we have to do like tuberculosis, pneumonia, malignancies, all these things we can differentiate on BAL. Biopsies, brush biopsy, endobronchial biopsy, transbronchial biopsy, hemoptysis to look for any source of bleeding. Foreign body, as we already discussed, TO fistula can be diagnosed on bronchoscopy. Vascular compression on trachea, we can see the collapsing trachea. Any subglottic stenosis, atelectasis, like we have already discussed that if any single lobe is involved, there is a collapse, then there may be either foreign body or mucus plug. Bronchiectasis, look for harboring organism, and we may get sometime diagnosis like cystic fibrosis on, depending on the organism. Any injury, thermal, chemical, toxic to the airways, we should do a bronchoscopy. Any unexplained respiratory condition, if you are not very sure, sometimes it may help. So it is depending on the situation, we can decide that thing. Therapeutic removal of the mucus plug, then total lung lavage. Difficult intubation, we can put a ET tube on the bronchoscope, and then we can do intubation also. Endobronchial toileting, or we can say bronchoalveolar lavage, therapeutic, or any sometimes peripheral foreign body retrieval can be done. So airway, like some interventions like balloon dilatation, tracheal stents can be done. So availability of the smaller size bronchoscope, the fact that it can be done under tropical anesthesia has made revolution in the diagnostic work of infants presenting with respiratory nausea. So we are also, as many of us know, that we have done so smallest baby is almost 1 kg. 1 kg baby also we have scoped, and 1.5, 2 kg we are doing it routinely. So thank you. Thank you.
Thank you, sir. That was a very nice presentation.
Thank you, sir, for such an interesting session. I would like all the dignitaries to proceed to the felicitation area.
I've got the esteemed panelist, Dr. Tushar Maniar from Mumbai, Dr. Uday Patil and Dr. Nivedita, both from Kolhapur. All of you know them. So we come across the combinations in all walks of life, be it politics or be it food. So medicine is not an exception. Even in medicine, we have got combinations. There are few which are rational, there are few which may not be rational. So the fixed dose drug combinations, or FDCs, not to mistake with the company FDC, they are acceptable only when the dosage of each ingredient meets the requirement of a defined population group, and the combination has a proven advantage over single compounds administered separately in a therapeutic effect, safety or compliance. And these are highly popular in our Indian pharmaceutical market and have been particularly flourishing since last few years. So my first question will be to Dr. Tushar Maniar. Dr. Tushar, what do you think are the advantages of the fixed drug combinations?
So, thank you very much once again. The major advantages of fixed drug combination, according to me, are when a patient is on chronic treatment and when multiple pills to be taken by the patient is reduced. So, the pill burden, as it is called, becomes smaller. That has multiple advantages in the way that the compliance is ensured, the load and the chances of error from the dispensing part and the administrative part is also reduced. Also, one more subtle advantage is if, for example, you take anti-TB treatment or antiretroviral treatment, if I was to give 4 different treatments from a government setup and one particular drug or 2 particular drugs are not available, the patient will be taking only 2 drugs which can have harmful effect rather than benefit in the form of increasing the resistance and causing a problem. So these are some of the advantages of fixed drug combination. Now when we say fixed drug combination, as doctor already said, if you are going to include 2 drugs by which one allows the other one to work better or improve the efficiency, then that would be another big advantage of using a fixed drug combination.
Excellent. So basically, combination therapy, reducing the number of pills, as we have said, diminishing the complexity and improving patient adherence. And of course, there are administrative, the administration cost also would come down. And also, it will be improving the compliance. As we know, in AKT or ART, this definitely has proven to be beneficial. So, about the disadvantages, I would like to ask Dr. Uday Patil, what do you think are the disadvantages for the fixed drug combination?
The major disadvantages being increases the side effects. If you give combination of mefenamic acid with paracetamol, mefenamic acid causes hematuria, thrombocytopenia, severe gastritis.
Yeah.
One is adverse effect. Second is increase the cost of medicine. If you want to go just plain paracetamol, but if you are adding ibuprofen or caffeine, that increases the cost of medicine.
Yes.
Third, if you add drug like iron to the B complex, it is going to be wasteful because B complex is the main drug, iron is an additive, but it is not going to be really helpful. Then if you want to titrate one drug in a fixed drug combination, it's very difficult, as in case of paracetamol with the mefenamic acid combination. If you want to increase the dose of paracetamol, it's very difficult.
Yes.
So titration becomes difficult.
So keeping this in mind, so basically if you want to add, there are going to be disadvantages. So you cannot have the titration of the drugs made properly, and the prices of the medication will definitely increase. Basically, I do not know whether how many of us really check the amount of money the patient is spending when he is buying a medicine, and in case we write down a combination, how much more he is shelling out from his pocket. So that is an important thing. And of course, one of the medicine may be just wasteful. And anything else apart from that will be adverse effects, which Dr. Uday Patil has already said. And in many combinations, there may be few medicines where the amount of medication, especially multivitamins, may be of such a small quantity. So it is not going to add to advantage, it is just going to add to the list of the medicines. And of course, the incompatible pharmacodynamics, which will try to see how the things are as the discussion progresses. And in case there is some adverse effect, it is very difficult to decide which one of these has really caused. Of course, in AKT we know in case the INH rifampicin pyrazinamide is started. So hepatotoxicity, which one of these has caused? We know by theory or by the experience that rifampicin is one of the major ones, but in reality, we do not know in that particular child which one has caused the problems. So, I would ask my next question to Dr. Nivedita. What are your expectations from a rational fixed drug combination?
Okay, so from fixed drug combinations, what we expect is the drugs which are included in the combination should have different modes of actions. Then they are likely to work synergistically. Second is because you are giving them together at the same time, their pharmacokinetics should match. For example, if both drugs have a different half-life, then it is very difficult to decide their dosing schedule. And their toxicity should not add up. Like for example, if you are adding 2 drugs which are both nephrotoxic, that's going to add to the toxicity. So they should not be adding to the toxicity of the each drug.
Okay, so the drugs in combination should act by different mechanisms. The pharmacokinetics should not be different and should not have a supra-additive toxicity, as she has rightly pointed out. So, what are the usual combinations which we are mostly using, Nivedita?
Yes. The rational drug combinations which we commonly use and are really helpful are, one is amoxicillin and clavulanic acid. That is definitely helpful. Second would be your iron with folic acid combinations, what we use. And maybe your sulfamethoxazole, and I mean Septran. Septran is time-tested, very good, helpful combination. And then your anti-COX treatment and antiretroviral therapy. So there we have to use combination drugs because they have different modes of action, and that prevents resistance because these drugs are used for a very long time.
Yes, and to add to it, of course, we do not need them in pediatric practice, but anti-Parkinsonisms like levodopa and carbidopa, these are the ones which have got a proven mechanism where these are rational combinations used. So, in reality, what are the demerits of this? The dosage alteration, Tushar would like to talk about the demerits of these current FDCs which we have got, apart from the ones which are rationally used. So
the biggest challenge is that whenever you look at any FDC that you want to use, you must make sure that per kg body weight dose is same for both the drugs. So if I'm giving it to a 10 kg child, if it is A and B, both A and B should have the same milligram per kilogram requirement. Both of them should be the same number of times that you will be giving. And not only that, one should not be SOS basis and the rest is to be given 3 times a day. I'm sure you know which ones I'm talking about and we'll dwell into them a little later. Also, some drugs will have different combinations at different times. Like for example, amoxiclavulanic acid, when you want to give amoxicillin at say 40 milligram per kilogram, the clavulanic dose will be at a particular level. But if you want to give a higher dose of amoxicillin, the clavulanic dose does not automatically increase. So you must make sure that you use the right combination of amoxi and clav. So if you're using a higher dose, use an ES preparation per kg I'm talking about. If you want to use the normal one, then you can use a duo or DS. That is what I would suggest.
So we have got one combination of coamoxi clav which is 228, which probably is rational. At the same time, because the dosage is not correct, probably the other one with 250 mg of amoxicillin and 125 of clavulanic acid may not be rational. Although the combination is correct, but here the dosage which are used are probably not correct.
Yeah,
right.
Just to say, repeat what I already said. If I want to use something in the range of 60 to 80 milligram of amoxicillin, I should use the one that is an ES, because then I don't want to give more of clavulanic acid along with that.
Exactly.
But if I want to use, if I want to use a 10 kg child and 80, I should not use 15 ml of 228 amoxicillin. I should go for an ES.
Okay, thanks. So these are the few things which are really causing demerits to this current FDC. So instead of talking about the theoretical part, I think we should go ahead with a case-based approach. So I think all the panelists would agree with me.
Sure.
So we'll try to have some criteria. Of course, not every time all these criteria will be checked and every time all these criteria will be seen. But we'll try to see what are the solutions for that particular problem, justification, the efficacy of that medication, safety, and of course cost effectiveness. So let us go one by one. There is a doctor who has diagnosed a dysentery in a 3-year-old male child, prescribed a combination of ofloxacin 50 mg and metronidazole 100 mg to be taken orally twice daily for 5 days. Now, I would request Uday to analyze this combination using rationality criteria. So
Here,
what do you say about this?
Here my diagnosis is a bacillary dysentery. My drug of choice is going to be cefixime.
Okay.
What combination is given in this particular is ofloxacin metronidazole. It's 2-drug combination. It's one is antibiotics, one is anti-amoebic. There's no concept like mixed diarrhea in our practice.
Yes.
We always deal with either viral diarrhea or dysentery or amoebiasis separately, but there is no concept of mixed diarrhea. So giving these 2 antibiotics together is irrational.
So from where does this term mixed diarrhea comes from? Anyone? I think it comes from the representative, if I mistake
Yeah.
not. Okay. So there is no justification here. So would you combine anti-amoebic with a fluoroquinolone?
We don't.
Okay. So do you think that this combination of antibiotic with an anti-amoebic is a rational one?
It's quite irrational.
Okay, fine. So the patient is suffering from only one type of diarrhea, so there is no need of having a combination. Will it add to the adverse effects and the cost?
Definitely. Adverse effects are more common with, if you go combine together, it causes nausea, vomiting, severe gastritis, that's what we see with ofloxacin. Metabolic test comes with metronidazole. So many other adverse effects are there. And definitely it is going to encourage resistance.
Yeah. So considering all these points, probably we may not be using these drugs. So if one drug is sufficient, we will not use another drug which is added, and we know that cefixime is good enough to take care. There is no need to add metronidazole over here. And he has already talked about the side effects of ofloxacin causing nausea, vomiting, abdominal discomfort, and will add to the adverse effects of metronidazole. And plus the half-life of metronidazole and ofloxacin are different.
Yeah, they are different. Ofloxacin is given twice a day, while metronidazole we need to give 3 times a day.
So now, is it that these are the only combinations which are available in the market, or there are more?
There are a lot.
So we've got norfloxacin, metronidazole, ciproflox, tinidazole, oflox, ornidazole. So they are not recommended anywhere in the standard textbooks. And at the same time, how many of us really do see proven amoebiasis, especially for a 1 year or a 2 year-old child? How many times do we see amoebiasis?
It's almost less than 5 years, hardly we see.
And in case we have got amoebiasis, do we need a use of antibiotic in that?
No need as
So
such.
using a specific anti-amoebic and followed with diloxanate furoate would be more than sufficient. Okay. Now, Dr. Tushar, we have got a 7-month-old male child, fever, cough, no vomiting, refusal to feed. He is otherwise stable, respiratory of 40, pulse of 130. There is no systemic signs as present, and my diagnosis is acute febrile illness. And my prescription is a combination of paracetamol and mefenamic acid.
Yeah, actually, I was trying to read what it is because I don't use this, and there is something and mefenamic acid. So I was trying to.
It's paracetamol.
So it's paracetamol. Good. So first of all, I have deleted mefenamic acid from my iPad and my electronic software, so that not only me, nobody else uses it by mistake. We are not here to discuss individual drugs, so we will talk about the combination. Here, it's like if you can kill somebody with 1 bullet, why do you want to fire 2 bullets? Not only that, if you are not sure whether you will kill somebody with 1 bullet, you definitely want to keep both bullets ready so that you shoot one, then see if it's working or not working, and then shoot the other one. So what I'm trying to say is, if you want to use 2 antipyretics, mefenamic not being in the picture at all, if you are talking about ibuprofen, if at all, if you rather use paracetamol followed by ibuprofen if need be, rather than giving both together, then you have nothing else to give for next 4 to 6 hours. So not to give 2 antipyretics at one time for sure, not to use mefenamic acid either alone or in combination.
So apart from that, what other disadvantage will you feel? First of all, there is no definite diagnosis, requires antipyretic, that too a solitary one. So mefenamic acid is an anti-inflammatory drug, whether it is indicated. Of course, the clinical experience has been that it brings down the fever very rapidly, but what when we use a combination, because the point of discussion over here is that of combination. So,
right. So that's why I'm not elaborating on why ibuprofen should not be used as an antipyretic or why mefenamic should not be used as antipyretic. I am saying it should not be used as together in single drug for sure.
So the same, in case I was to change this to apart from rather than paracetamol with mefenamic acid, if I was to put down paracetamol with ibuprofen, then probably your answer would have been the same.
Right. It would be same, but the only modification would be At the most, I'll tell the patient, if you have history of febrile seizure, if your fever is not coming down below 102, even after giving paracetamol and tepid sponging, you may, I know this is controversial, but I would say, okay, in practice, use a dose of ibuprofen, but not together for sure.
Yeah. So, and by using
so basically, that is one brand which I know, that's why I'm saying, no plus to be used.
Okay. So basically, plus add to it the half. Yeah.
Can you get a single ibuprofen syrup? As you get?
Yeah, you will get. Yes. So using two different antibiotics at different times would be probably a more rational choice rather than using
it's not FDC. Completely rational, but at least it's less irrational. That is how I would say it. And I do use sometimes the irrational thing. So I'll be open with you. I am sure all of us sitting over here use FDCs, but what we are trying to give a message here is how to make sure that we do least harm, if at all we do any harm.
And keeping in mind that the half-lives of both paracetamol and mefenamic acid are different, he has already mentioned, even if you talk about brufen, probably the half-life of both...
Same thing. No. Again, ibuprofen is 8 hours and crocin is 6 hours. So again, going a combination doesn't make sense at all.
Yes. So I would rather not use it.
Even the per kg body weight dose-wise, if you want to compare,
yes,
they both, all the combinations contain 100 milligram, 100 milligram. Whereas you want to give 15 milligram per kilogram of paracetamol, but you want to give 10 milligram per kilogram of ibuprofen. So even that way, it's not a rational choice to use a combination.
Yeah, and add to it, because of these different half-lives also, in case somebody has to repeat, in case somebody has prescribed it, and in case someone has to repeat the dose, after how many hours you are going to repeat that dose? Because in case it is early, then you are going to give one more drug in a slightly toxic dose. Okay. Now, going to the next case, 1.5-year-old male child, common thing which we are going to see in due course of time. Probably right now we are not seeing anything. Fever, cough, cold, dry cough for 2 days. And child is afebrile, minimal respiratory distress or no distress, no adventitious sound, upper airway infection. Put on this cough syrup with phenylephrine, chlorpheniramine maleate and dextromethorphan. So, Dr. Nivedita, your comments on this?
Yes, so this combination is phenylephrine is a systemic nasal decongestant, chlorpheniramine is first generation antihistaminic, and dextromethorphan is a centrally acting D-isomer like codeine. So here, this looks like a case of cold with a dry cough. So in cases of cold, I think CPM or the first generation cephalosporin are discouraged in children below 2 years. So that shouldn't be used, and at this age you can prefer a single antihistaminic like maybe cetirizine, and one should think whether we really need to add a systemic decongestant, because when you have an option of nasal decongestant, whenever you can use it on SOS basis, like when the child gets nasal blockage, you can use normal saline drops. It is very severe, causing sleep disturbances in the night, you can go for xylometazoline, but a systemic decongestant is not advised because it has more side effects, like the child will come with irritability, hypertension. We have even seen SVTs, the children landing up with SVT when you prescribe for less than 6 months, where it should not be prescribed at all. About dextromethorphan, see, cough is a protective reflex like fever. You need not treat it. Okay, if it is very severe, causing disturbances in sleep, and the child is becoming very hypoxic with the episodes of cough, is very severe, affecting the daily routine of the child, only then you can use cough syrups for dry cough. But dextromethorphan, I think it is not advised in children below 4 years. So one has to be very careful giving mixture of coughs, the most irrational combination of cough-cold mixtures.
Yes.
So here I think plain antihistaminic would suffice, and that too is not going to reduce the duration of cold. It will just reduce the severity of your runny nose, itchy eyes and coryza.
But then the parents are complaining that they want a relief for this child. So how do we go about it?
For the cough you mean?
Yes.
Yes. So I mean, what I do if they say that we give honey or kada, and I say, yeah, okay, you're doing a good thing. At least that avoids prescribing a cough syrup. Let them do that if it is not harmful. Yeah. That the soothing and homemade remedies are really helpful, and otherwise mild cough does not need anything.
So, yeah, Tushar wanted to add something.
So this is not just that we are sitting on the dais, we'll say something. When we come on that side, we'll sit and write something else. After the Delhi episode of dextromethorphan related deaths, there's a government advisory of not using dextromethorphan at least below 4 years of age. So please avoid using dextromethorphan below 4 years of age. And so is an IAP advisory of not using systemic decongestant in smaller children. I'm not sure whether it is 6 months or 1 year, but please be careful about writing something, because if you use something and if things go bad, then you have no protection.
Yeah. So there are multiple factors involved in this. Add to it the dosage, probably milligram per kilogram.
Below 2 years, all these drugs not to be safe.
Yes.
Drug safety and other things are not well established.
Yeah, because the product enclosure will say that these are not tested below 2 years of age.
Dosage, efficacy, safety.
Exactly. Then we have got 1 year old male child, cough, cold, fever. He's got fever, his throat is normal, RSCV is normal. His child is put on a combination, you can read, some fever plus medicine, which contains chlorpheniramine maleate, paracetamol, and phenylephrine. Nivedita, again a take.
Yeah. So here you need antihistaminic only maybe, and even if you decide to give an decongestant for an older child, that has to be given round the clock. And paracetamol is a drug which we use on SOS basis. So what happens is when the child is having only cold and no fever, parents land up giving paracetamol round the clock when it is not required. And second, I have seen parents coming with the older prescription or the older sample and they use it for fever and not when the child doesn't have cold. So that that becomes adding of drugs which are not necessary. And here when CPM is 1 milligram per 5 ml, some preparations have 2 milligram per 5 ml, and it's very difficult to titrate doses of CPM and paracetamol.
So as Tushar sir has rightly said, that paracetamol is something on an SOS basis, whereas the other drugs have to be given in a periodic, specific frequency.
As your title says, whether it's an addition or subtraction, simple message is plus is to be avoided. Plus does not necessarily mean positive.
Plus does not mean plus, it's actually plus is minus over here. So, and add to it, they have got different half-lives, so they should not be used in combination. So, as we have said, it's a necessary evil, so cough and cold combination, there are so many of them. So what all points will you consider? This question is to both Tushar as well as Nivedita. A combination of cough suppressants with mucolytic, antihistaminic with mucolytic, bronchodilator, mucolytic, and dosage of each ingredients and dosage frequency. How would you go? Because we have to pen down something.
So first one is simple. Cough suppressant and mucolytic, no. Antihistaminic mucolytic, no. Again, because antihistaminics typically have anticholinergic effect, they dry, and mucolytic make it wet. So I don't know how they both are, who's going to win the battle. Bronchodilator plus mucolytic may be allowed. Again, technically bronchodilator should be inhaled and not should be given orally, but we all do give it. And so if you have to give it, I would allow that. Dosage of each ingredient, as I said, has to be matched per kg body weight. And if it is not matching, then the one with the narrow therapeutic index should be given a priority and their dosage has to be followed.
So we will follow the one which has got a narrow therapeutic index, and that would...
Yeah, generally in real life that would not happen because the mucolytics that you are going to act have no per kg body weight.
Yes.
But all the same, you want to make sure whether you are eating 15 milligram of ambroxol or 30 milligram of ambroxol. That's what you want to check on that. And dosage frequency, again, if you are talking about cough cold medicine, the only thing for dry cough, if you are talking in a bigger child, a first or second generation antihistamine can be used alone.
Yes.
Or otherwise a first generation with a cough suppressant can be tried.
Would be. Thank
Okay,
you.
one thing I would like to add here.
Yeah.
See, we should understand how a mucolytic works and how an expectorant works. Mucolytic actually going when you have thick tenacious putum, which is very, in very few conditions in pediatric you get that, like say cystic fibrosis, bronchiectasis, where you want to make the mucus, existing mucus thin. So you're breaking the disulfide bonds, and expectorant actually stimulates the respiratory tract to increase the secretion. So it is going to increase the volume of the secretion.
Yes.
So when you hear the cough and you see it's a wet cough, actually prescribing expectorant may worsen the cough in 1 or 2 days. But actually when it is doing its job, we should convince the parents that it may worsen, but ultimately the child is going to come out of that. So that is very important. And as he said, dry cough, older than 4 years, you may prefer dextromethorphan
yes.
in children above 4 years.
Okay, thank you. Now we have got another child, 4-year-old male, skin eruption over body, pruritus, there is history of excessive perspiration, is slightly obese, and on examination findings are suggestive of a fungal infection. And this is his 2 creams which have been prescribed for him, one miconazole, clobetasone, and one either with neomycin or with gentamicin. So Dr. Uday, what do you think?
My diagnosis in this patient is fungal infection.
Okay.
What he needs is local antifungal like a miconazole for a period of 4 weeks. This triple combination what you mentioned, it contains antifungal, antibiotic and steroid. The steroid is definitely going to mask the inflammation. The patient comes to you and patient land after 4 days to another pediatrician or skin specialist. Ultimately, the diagnosis is going to change because of steroid. Because steroid is going to mask the inflammation. And adding antibiotics is not going to really help. Unnecessarily, you are going to induce resistance for that particular antibiotics, giving this antibiotics in this particular regime.
And add to it, in case we are using these aminoglycosides, the topical use is going to sensitize the child.
Definitely.
So that is yet another complication or problem which we are going to face. Yes. So why do these so-called triple creams come up? Anyone?
As such, there is no need. It is quite irrational combination.
It comes because the medical representative promotes that.
If
you don't have a diagnosis,
if you don't have diagnosis, then you use all this combination.
So are we really justified in using this?
No.
Yeah.
Absolutely.
One more point here was, I don't think we mentioned age of the child, but clobetasol is a very strong steroid.
Exactly.
So
it's a very
since
strong.
we are talking only of combination, we are not going into that, but when you write any triple drug, your focus for antifungal will be on miconazole, but you are not paying attention to which other steroid is going in that cream.
And so clobetasol is very potent.
It needs to be taken care.
And the person next, because these patients are likely to move from one pediatrician to the other, and the next one which he sees, he is going to see an altered picture. So he really won't know exactly what has been treated. And this is going to cause this, the local steroid is also going to cause a problem, the thin papery skin, etc. All these combinations would come. And the most important thing is, all of us know that we have been facing a problem of resistant fungi. We talk about this luliconazole and other things which we hardly need to use, but currently the situation is that the fungus has become resistant. And one of the major reasons is these so-called triple creams. So these Amar Akbar Anthony's may not be working for us. They may be actually in reality 3 idiots. So next one is a 4-year-old male, 10 days fever, 16 kg, poor appetite, febrile, toxic, soft, and has got palpable spleen. His diagnosis, culture has proved to be Salmonella typhi. Fortunately, till the time his culture was done, he had not received any antibiotics. And this is the combination, cefixime and ofloxacin, given in the dose of 7.5 ml twice a day, and paracetamol. So, Tushar?
Again, we know that fluoroquinolones are of no use in India for enteric fever. Okay, I'm going to make a blanket statement. You can present a case with sensitivity and discuss about it. Routine practice, only cefixime for children who are stable and can be managed on OPD basis. If unstable, to admit and give IV ceftriaxone or any other third generation cephalosporin. So combination is of no value. You are adding ofloxacin for no reason. Anyway, it is already showing resistance, so I don't see any further resistance being increased. It'll add on cost and side effects and give you a false sense of security.
So why would one add a fluoroquinolone when the better alternative is available? And in the first place, in India, we do not see the bug to be sensitive to fluoroquinolones. Fine. Now, last one, A 2-year-old male child, 12
regarding,
kg.
Regarding when the cost of that particular things.
Yeah, and yeah.
Because what the combination you are given, that he's having 50 mg per 5 ml. And if you want to give for a 16 kg child,
Yes.
we need to give every day 1 bottle.
Yes.
The 14 bottles will cost you almost 1200 rupees or more than that. And while dose of cefixime 20 mg per kg per day, that will cost you something around 200 rupees.
Yes. So in case we have got a higher strength of this combination, again the cost would go up and unnecessarily so.
Yes.
Okay. Now this is the acute suppurative otitis media put on this combination of cefpodoxime and potassium clavulanate. Uday,
yes.
What is your take on this?
This is otitis media proven. My drug of choice is going to be amoxicillin.
Okay.
If patient is not responding within 48 hours of amoxicillin, then I'll go for amoxiclav.
Okay.
Or whether patient has received amoxicillin.
I would like you to comment on this
particular
combination.
Definitely this is an irrational combination. I may think of using cefodoxime in a less hypersensitive patient instead of using this combination.
The question is whether you will add clavulanic acid
No, we will not add because cefodoxime is the stable beta-lactam.
Okay.
It doesn't require adding of clavulanic acid.
Okay.
So this combination is irrational.
So the usual combination which is done is amoxicillin, clavulanic acid, and over here it's not a combination, it's the adjuvant. The clavulanic acid is working as an adjuvant. When we have this ceftriaxone tazobactam, cefpodoxime clavulanic acid, then cefixime clavulanic acid. What is the Tushar, would you like to throw some light?
So in my opinion, you use clavulanic acid for beta-lactamase to prevent beta-lactamases destroy the antibiotic. Now, clavulanic acid will protect not against ESBL, it will only protect against the certain older or first discovered or stable, whatever you want to call it. And they destroy the amoxicillins, the penicillins. They do not, if there is a third generation cephalosporin, like cefpodoxime or cefixime, they are not affected by those beta-lactamases. So to re-say the whole thing, use clavulanic acid will be useful only against things which will destroy penicillins. The bugs will anyway be killed by cefpodoxime alone. So adding clavulanic acid will not help. On that other way, if there is an ESBL, anyway clavulanic acid is not going to work and cefpodoxime is also not going to work. So adding them together will also not.
Yeah, so not only the combination harmful, it is likely to again increase the cost, increase the side effects. So that's the message. So what the Indian scenario is, we have got variety of these combinations and usually 2 drugs are sold when one is needed for the patient and combined pills are marketed. And the slogans like ibuprofen for pain and paracetamol for fever, and ibuprofen for peripheral action, paracetamol for central action. I do not know from where this theory comes in. And why do these things happen? Why do these things thrive? Because they are highly popular, made popular by representatives by highlighting the double benefits of a particular drug without discussing the pharmacodynamics and the kinetics. And doctors rely more on the representatives. It's slightly a dangerous statement, but I would still like to, this is the reality. Rather than going to the textbooks and journals, then probably that is the reason why these combinations, particular combinations thrive. So the other reasons, what all are the other reasons in this? Because we are running short of time, I would like all of you to comment.
I think one other reason is that some of the drugs have become so popular with the parents and the adult patients, like the classic one being Combi --. So everybody has that with them. Everybody finds it very useful, and it is one of the irrational combination because it has 400 milligram of ibuprofen and 325 milligram of paracetamol. I see no weight group that you can use. So one thing is that some drugs have been popular and they are being used. The other thing is that we as doctors have very little time to go back and probably read or check a new compound that comes in. So we tend to accept whatever is being told to us, and that should not be an excuse. my idea for this probably is that I keep my number of drugs very small. Even if a new drug comes, does not necessarily mean that I need to use it, whether it's a new combination or a new drug.
Drug by itself.
Most of the time, we are happy treating 95% of our patients with our existing drugs, which have been there for many years.
So even
lastly, as we were discussing earlier, the one way out of this is we should have one single database or kind of a pharmacopoeia in India of all the brand names, all the products that are available and the details of their own. Today, if I have to find out what that compound with mefenamic acid was, what I will do is I'll go on 1 mg or some other pharma.com and try to see the composition. And that is where I get my information. So that's not very accurate and very reliable. So we should look forward to having something from DGCA or IAP. Thank you.
Okay. So we'll just run through this. Lack of diagnostic facilities, demand from the patient, as he has correctly said, defective drug supply systems and ineffective drug regulations, promotional activities of industry. So all this is going to act, and we have to always keep in mind that in case there is any adverse reaction due to FDCs which are irrational, you are liable for suit in the court of law, and you cannot justify that I've used this particular combination simply because it is popular. So this is one thing which all of us should be really be aware of. So what all we can do, as a practitioner, I should be checking the credibility of each of these FDCs before I pen them. And as Tushar has already said, we should have a strong database independent of the pharma, and we have to really think twice when we come across any of these FDCs. So what are the contraindicated ones quickly, Uday? The ones which are really not needed. So antibiotic, anti-amoebic.
Mefenamic and paracetamol, nimesulide paracetamol.
Yeah.
Then cefotaxime clavulanic acid, cipixim clavulanic acid.
Okay.
Cipixim ofloxacillin.
Can be used with caution.
The cough syrups and the cold preparation mixtures.
Yes. And definitely good to use.
Cotrimoxazole with
Amoxiclav.
Okay. And your AKTs and ARTs. The best combination in food is dal khichdi, which is combining both, advantage of both are there. There are multiple combinations which are beneficial and are great. There are few combinations which may be okay for the time being, but these are definitely not. So O2 and CO2 today, maybe we will get drugs named HNO3, H2SO4 tomorrow. Thank you.
Paperwork, medical certificates in pediatrics. We all do have at least one faculty in our residency or registrar period that emphasizes on paperwork just to make us aware of its importance before the court of law does it. Hence, the next session, which will be chaired by Dr. Ramesh Nigde sir and Dr. Rahul Chavan sir. The speaker for this session is Dr. Ram Gopal Chejra sir. Dr. Nigde sir is senior and very well renowned pediatrician in Kolhapur, and Dr. Rahul Chavan sir is renowned pediatrician practicing in Ichalkaranji.
Hello. Dr. Ram Gopal Chejra is a very renowned pediatrician from Thane. He is a president of Maha IAP at present. He has a very good experience of 22 years. Now we are very fortunate to hear from him the unlocking of the papers work. Okay, so sir, over to you for next 30 minutes.
Good evening, friends. No reply. Okay, thank you. See, we all issue certificates in day-to-day practice. without knowing the importance of the certificates. The relatives comes, our child had not gone to the school, kindly give the certificate. And in good faith, we always give the certificate. So I think after this lecture, at least you know, you would learn to say no to the parents issuing a certificate without seeing the child. So what is a certificate? A certificate is a written document containing an authentic statement, especially to the truth of something. Now, what are the types of certificates generally we issue? The doctors may issue two different types of certificate. One is a medical certificate and another is a medico-legal certificates. So what are medical certificates? Medical certificates may be defined as a written statement from a registered medical practitioner or another medically qualified healthcare provider which attests to the result of the medical examination of a patient. For example, birth certificate, death certificates, medical illness certificates, age certificates, disability certificates, etc. Here, authorization from a competent authority like a police investigation officer or a magistrate is not required. The patient or the patient party may go directly and get the certificate from the doctor. Now we come to the point, what are the medico-legal certificates? They are written documents prepared by the registered medical practitioner for the legal proceedings. They are also known as medico-legal reports. Now, doctors issues medico-legal certificate on request of a police investigating officer or a magistrate. They should be given only to the police investigating officer or a magistrate free of cost. Example, post-mortem certificates, sexual offenses, examination certificates, drunkenness certificates. Now, what is the ethicality of the certificates? So in India, it is governed by the rule framed by the National Medical Commission under the Code of Medical Ethics 2002, amended on 8th October 2016. Under Chapter 1, Clause number 3.3, there is a clear-cut guidelines that the certificate shall be prepared as per the format given. The registered medical practitioner should maintain a register of medical certificates mentioning the full detail of the certificate issued, which normally nobody maintains. We just write the certificates and we hand over to the patient. The certificate issued must contain at least identification marks, signature or thumb impression of the patient. Now we are having a minor, so we need to take the signature of the parents. Now this is the certificate's format. Now whenever you will go to the medical council sites, you will get now the format of the most of the certificates. So you can download and use that formats of the certificates. In case of a illness, the certificate, the treating doctor must examine the patient by himself, and the certificate must also contains the exact nature of the illnesses and the probable period of expected absence if one can justify the probable cause of disease or the elements. The doctor must never issue such a illness certificate where he has not trained to treat or his specialization is different. Like we are pediatrician, we should not issue a certificate for an adult person. We cannot issue a certificate for the gynec purpose. So please issue the certificate of your own specialty. The most important part of the certificate, now I come on the death certificates, where majority of the people makes the mistakes. Now, a doctor must issue the death certificate if he has attended the patient while he was alive and he has attended the patient within 14 days before death. He himself is satisfied with the reason of the death. The physician who is treating the patient for minor illnesses or the disease should not issue the cause of death. In case of a medico-legal patient or suspicion, the doctor should not issue the cause of death. a copy of certificate must be kept with the issuing doctor, and all the documents should be maintained for at least 3 years. See, what the common mistake we do is, whenever there is a death, most of the time you will get a call from some politician, ये मेरा पहचान वाला है, डॉक्टर साहब इसको सर्टिफिकेट दे दीजिए. I'll give you one example. There was one doctor in Mumbai. The corporator called him to issue a certificate. And he had not seen the patient. Just by sitting in his clinic, he issued a death certificate. And unfortunately, the relative had gone to another doctor before calling him. So that doctor suspected something and he informed the police that they had come for a certificate. And this fellow had issued a certificate. He was arrested, he was made a party to the offense. And his license was cancelled definitely, and it was a non-bailable offense. He got bail after 6 months. So be very confident at you have to say no whoever calls you, unless until you have not seen the patient, so you are not authorized to give the certificate. Now I come on the how to fill the death certificate, because a lot of people, they do make a mistake in writing the death certificate. You must have seen the certificates. There are A part is to be filled up with where the 3 things: the cause of death, where it is immediate cause, antecedent cause, and other significant conditions. And there would be a below small slip. Usually we fill this slip, hand over to the relatives, take the sign that they have received the certificate, and that other part goes to the municipal corporation. Now, see, there are 3 parts where normally what we do is, in the residency also, the resident just write cardiorespiratory failure. Now, this immediate cause is not cardiorespiratory failure. I'll come on the example, I'll tell you with the examples. This is the format of the certificate, and you can just read behind the certificates. Government has given a clear-cut guidelines how to fill the form. If any, see, you can see the direction for completing the form number 4A. These are the direction. Because of the shortage of the time, I will not read. See, now here, the manner of death. Death not due to the external cause should be identified as natural. The cause of death is known, but it is not known whether it was a result of an accident, suicide, or homicide. See, there is always a column in the death certificate where you have to specify whether it is a natural death, whether it is a suicidal or homicidal. Now, the most important part for us, do's and don't do of the death certificate. First thing, clear, legible handwriting. No mistake about the age, sex, and name. Causes, disease condition directly causing death. Example, refractory CCF, septic shock. Now, second thing is your antecedent cause, morbid condition giving rise to other significant condition contributing to the death. Now, no cardiorespiratory arrest, it is the way and not the cause of death. Death certificate is to be issued free of cost. Not to be withheld for pending fees payment. You cannot withhold the death certificate because the patient has not paid the fees. Only a single copy of death certificate to be issued. Always maintain a carbon copy. Death certificate should be issued by a RMP who has been the medical attendant of the deceased during the life, has attended the patient 14 days prior to death, satisfied as to the cause of death himself or herself. Even if you have seen the patient, but if you are not satisfied for the cause of death, please do not issue the certificate. In which case, you should not issue a death certificate when the treating doctor is not sure about the cause of death. Death on arrival. Sometimes the patient comes and as soon as he enters into the hospital, you see that the patient has just died. So in that scene, you should not issue the death certificate. Intraoperative or anesthesia death. Injury played a part as to the cause of death. Burns, poisoning, medico-legal cases. Here, the PM is compulsory. You should not issue the death certificates in the medico-legal cases. Possibility of suspicious death. Now, I'll come again, one more important part, how to fill the death certificate. I'll just tell you the case scenario. A 59-year-old male was admitted to the hospital with shock with the sign of septicemia along with the gangrene of left foot. Patient had a swelling of it, foot and fever since 3 days. He had history of COPD due to chronic bronchitis and had diabetes since 5 years. Patient had diagnosed as a carcinoma of pancreas and operated for the same 5 years back. Patient died 2 days after admission due to septicemic shock. The cause of death. Somebody has written the certificate like this. Is it correct? Can anyone? What should be the cause of death? Then, so the correct cause is septicemic shock with the gangrene of the left foot, diabetes, and the pancreas, what is just may or may not contribute to anything. Now I come to the second case. 22-year-old female admitted to the hospital in conscious stage and a history of vomiting. Patient was in shock and had systolic blood pressure of 80 mm of mercury. She had history of consumption of organophosphorus compound 6 hours back with intention of self-harm, showing pinpoint pupil fasciculations. After 2 hours, patient developed respiratory paralysis and pulmonary edema. Patient was resuscitated but died 4 hours after admission. Body sent for the PM. So any cause of death? Yes, definitely the treating doctor should not issue the certificate, and after PM the certificate would be like this. There was a respiratory paralysis with pulmonary edema, then poisoning by consumption of OPC, and whatever. Then below, if you see, there is a manner of death: natural, accident, suicide, homicide, pending investigations. So here it is with clear intentions of suicide. Now, a 26-year-old second para delivered a male child having completed 32 weeks of gestation. At 7:30 p.m., baby was premature, having birth weight of 1350 gram. After birth, baby had a respiratory distress. On examination, baby was hypothermic and had a blood-stained froth at nostril and mouth. In spite of treatment, baby deteriorated and died on 16/12. That means on the next day. The diagnosis was suggestive of a pulmonary hemorrhage. How will you feel the cause of death? Any suggestion? So the cause of death was pulmonary hemorrhage, respiratory distress, and the contributory factors were respiratory distress with hypothermia and prematurity. So these are the examples. Now the take-home message, I'm not taking the much because already we are quite late. So the take-home message for the certificates are that you should not give the certificates without examination. Don't issue a false certificates, because there are 4 to 5 cases where the license of a doctor has been terminated on the issue of the false certificate. So don't issue a false certificate. Don't issue a certificate to the other than your own specialty. And the death certificates unless until you have seen the patient in last 14 days and you are sure that yes, it is a natural death or you know the cause of death. Unless until you know the cause of death, you just deny. Sometime you get a political pressure, always you can say that you don't know the cause of death, and that is why you cannot give the certificates. Okay, thank you.
Hello. Thank you, sir, for putting light on very important and neglected topic in our office practice of certification. Thank you. Thank you very much.
Thank you, sir. Thank you, all the respected faculty.
Time. You look at.
No questions? Yeah. Thank you, sir. Thank you, sir. I request all the dignitaries to proceed to the felicitation area. Arrived already, the respiratory infections have come along too. So the next talk is to discuss approach to a prolonged pneumonia by Dr. Sushil Kabra, sir. The chairperson for this session will be Dr. Shishir Mirgunde, sir, who is pediatric nephrologist and medical superintendent at RCSM GMC and CPR Hospital, Kolhapur, and Dr. Vijay Gowde, sir, who is a consulting neonatologist in Kolhapur.
Today's speaker, Dr. Sushil Kabra, sir, is a renowned pediatrician, known figure in our country, and his faculty at All India Institute of Medical Sciences, Delhi, and he has been editor-in-chief for Indian Journal of Pediatrics, a renowned journal in our country. And sir has contributed to so many chapters in various books. So without much ado, we'll request sir to proceed.
Respected chairpersons and friends, it is a great pleasure to be here and interacting with you people. So I'll be talking in 25 minutes or so regarding approach to a prolonged pneumonia. So first and foremost in the clinical practice is that commit to a diagnosis. If I am seeing a child, whether it is a pneumonia, asthma, tuberculosis, enteric fever, or some other problem, commit to the diagnosis. Be ready to revise it if required. If I have failed in diagnosis, then don't worry about it, that I'll change the diagnosis. If I have seen a patient that the acute gastroenteritis, no dehydration, probably a viral gastroenteritis, then if I am adding antibiotics subsequently, then I'll change it, that it is probably a bacterial. Okay, so I am going to discuss these cases, and majority of the patients can be managed by first 1 or 2 steps. So what is prolonged pneumonia? All of us are seeing pneumonia, and what is pneumonia which is not responding to standard treatment on expected line. And we'll discuss that what is the expected line. Then pneumonia taking longer than usual time. Persistent pneumonia is no response in 4 weeks when there is a radiology as well as clinical features. And recurrent is if there are 2 episodes of pneumonia which has cleared and then recurred in 12 months or 3 in any time frame. So course of pneumonia, we need to know that if I am treating pneumonia, what do I expect? So clinical improvement happens in 48 to 96 hours in majority of our patients if it is a community acquired pneumonia, and fever can last for 2 to 4 days. If it is showing, but it will start showing some improvement in 2 to 3 days. Leukocytosis usually resolves by day 4 or 5, and physical findings may persist for more than 7 days. So this is a usual pneumonia which we see in a community acquired pneumonia, that child will show some improvement in fever first, then leukocytosis may resolve, but crepitations or some abnormal finding may persist for 7 days. And radiographs may worsen even though clinical picture is improving. And chest X-ray usually return to normal within 6 weeks. In some conditions, it may go on. So it is very important to highlight that persistence of few crepitations is not a prolonged pneumonia. Persistence of X-ray shadows is not a prolonged pneumonia if patient is clinically improving. So causes, what are the causes of poor response? So one is inadequate treatment, inappropriate antibiotic, then improper dosage and duration, and improper route of administration. Then unusual organisms. Say generally once we say it is a community acquired pneumonia, strep pneumonia, Haemophilus influenzae, these are the two common, and Staphylococcus is the third one. But it may be because of tuberculosis, viral agents, atypical organisms like chlamydia, mycoplasma, legionella, gram-negative bacilli, fungus, and PCP, which is more commonly seen in a immunocompromised state, and drug-resistant organism. So it will be a small proportion of patients who may have a drug resistance. And if a patient is continuing to have fever on day 3 or 4, but clinically improving, it doesn't indicate that it is due to drug resistant organism. So underlying disease, it may be immune deficiency, malformations, cystic fibrosis, primary ciliary dyskinesia or others, and there may be some complication including pleural effusion, developing lung abscess, infections in other parts of the body. So what should be my approach when I am seeing a patient in my clinic or in hospital or in OPD? First and foremost is it pneumonia? Is the child receiving appropriate antimicrobial agent, dosage, route of administration, duration? If a child is clinically improving, stable and not worsening, that is the most important thing for a clinician. Is there a possibility of unusual organism, any underlying disease and complications as I had seen? So first let us see, prolonged pneumonia, is it pneumonia? So rule out mimickers, like we make a diagnosis of pneumonia when a child is having some cough, fever with tachypnea or breathing difficulty. So other causes which may mimic that of pneumonia is anemia. Then there may be acidosis because of say some various causes including say gastrointestinal losses, or it may be RTA or other causes, heart diseases and neuromuscular diseases. So that should be kept in mind, that whether is it pneumonia or it is tachypnea due to some other cause, extrapulmonary cause. So let us see this 8-month-old resident of Allahabad presented with acute onset cough, fever and respiratory distress 2 months ago, when child was fed dal forcefully and hospitalized and treated with oxygen, IV medication, IV fluid and nebulization, and fever got relieved in 5 days, but cough and respiratory distress was persisting. And in view of persistent symptoms and some abnormality on X-ray, the treating physician thought that it may be tuberculosis because that is the common cause in our country. And then when we were taking the history, he vomits out whatever complementary feed was being given to the child. Heart rate was 150, tachypnea is there, 64 per minute at 8 months, and there is some hypoxia in room air. It is 90 to 95% oxygen saturation. Breath sounds are decreased on the right side, crepitations are present right more than the left side. Hemoglobin slight anemia, but counts are very high, 34,400 with 70% polymorphs. So any doctor will think of it and then will decide that first give a ceftriaxone, then meropenem, vancomycin, and then colistin and all those things. So this was the X-ray. You can see here that there is a patchy area of dense consolidation bilaterally, but more on the right side, and CT is showing this thing. So this should be, I see some young people, if there are some residents, that if a child is being fed forcefully and we feel that he has aspirated, then if it is an infant, it will go in the dependent part, upper lobe, posterior segment. If it is in slightly bigger one, then lower segments dependent part. So you can see CT, significant consolidation, and in first contact, if someone has started on anti-TB drugs, it's fine, but think that if 34,000 counts with 70-80% polymorphs, you are justified in considering this thing. But if you take a history that what kind of pneumonia it is going on, that it happened after giving a forceful dal feeding, and child did not like it. So because of persistent pneumonia, you will do some investigations including culture, procalcitonin, CRP, bronchoscopy, bronchial lavage for TB, bronchial lavage culture, bacteria, barium swallows, GR scan, total IgE and sweat chloride. You can see all were within normal limit. And because child was suffering for 2 months, so the treating physician thought that it's right. So it was confirmed that it was a hypersensitivity pneumonitis due to lentil, the dal which is gone into the abnormal site, that is lungs, and hypersensitivity was responsible for persistence of shadows along with that high total leukocyte count, which was polymorphonuclear response. And we were seeing this type of patients, dal feeding. All of us advised the parents to give a complementary feeding in form of a dal and khichdi. And you will not be surprised to see many of the mothers that they'll hold the hands and then give it in the mouth and then the child gets it. And if you take a history that it was sudden onset, if it was a gradual onset going on, then you'll think of TB and the thing. But it was sudden onset after giving this thing, and we struggled a lot. This is a work of 1.5 decades or 2 decades. So we developed this because if you say that it is a hypersensitivity, it is not a pneumonitis, then you have to document that there is an increase in the IgG. And that was very high, and none of the laboratories were doing it, so we developed our own assay. And it was not this thing, anaphylaxis, because that would be Ig mediated. So oral steroids were given, and you can see the difference. ATT was stopped, and respiratory rate reduced from 64 to 38. Oxygen saturation was there, and gaining weight and X-ray, there was a significant clearance. So aspirated food content, hypersensitivity, some of you may be aware about the environmental factor, like inhaling something which is noxious may be causing, but this is aspiration, which is more important for pediatrician. And it was not an infectious agent, but it was a non-infectious agent. So it is important to understand that, and we should be aware. I have kept this case because I feel that it is relatively more common in our setting, and instead of giving a lot of antibiotics and anti-TB drug, we should be aware about this, this thing. Take a history that this patient was going on to many people, and then they were giving one after the other. But when we took the history, because we were sensitized, we had a few cases like this, so we sensitized, and then that's why. And now it is internationally known that lentil hypersensitivity is a condition which has been reported from India. Is the child receiving appropriate antimicrobial agents, doses, route of administration, and duration? So it is important for us, for a clinician, that whenever we are treating, and if a patient is not responding, whether it is a first contact or second or third contact, think of what antimicrobials he is getting, he or she is getting. Then doses and route of administration, and as we had seen in the previous session, combinations and irrational combination, irrational doses. So that is very important to understand that patient is getting appropriate treatment, and majority of our patients would come under the, till this time. Is the child clinically improving? So we have to ask the details. Subjective well-being, oral acceptance, check the trends of the temperature, that it is going down, respiratory rate, heart rate, chest indrawing, good oxygen saturation, all these things. And then let us see this patient. This is the 12-month-old, fever, cough, breathlessness for a month, heart rate is 120 per minute, respiratory rate is 48 per minute, and there was subcostal and chest indrawing. And there is mediastinal shift to right, resonant percussion note on the left side, and decreased breath sound on the right side. And there is a bronchovesicular sound with the crepitations on the left side. And you can see this X-ray. So this X-ray is showing multiple dilated, thin-walled cavities which are under pressure. That's why it is going towards the other side. And CT scan confirms this thing, and there is a air fluid level also. So because of air fluid level and report by the radiologist, a diagnosis of empyema thoracis with some staphylococcus was made, and then a chest tube was inserted. There was some improvement. So then, as usual, we get worried. Parents are worried. The doctor gets more worried. So consulted pediatric surgeon. Pediatric surgeon said that there is another loculus of the air, put another tube. So they put another tube, but no significant radiological improvement. But child remained afebrile, and there was decrease in the respiratory rate. And then there was this thing that we'll put a third because there is another loculus, but child was more wise. He pulled out all the tubes, And since he was otherwise okay, he was improving, we took this thing that this was done in our hospital under our care, say 20 years ago. So we can make a mistake. So we thought that now since the child is improving, I said that I take the responsibility and will not reinsert any tube, send him home, and then we call him after 2 weeks, and then we saw that there was a completely normal X-ray chest. Then we were very happy, residents were very happy that this is very unusual. And then we were reading the textbook of Nelson, and it is written that after the infection is getting controlled, there may be some air cavities and which may resolve over a period of time and doesn't need any treatment. And if you do a blood culture or other thing here, they will be negative. So this is the important thing, that if a patient is improving, not to treat the shadows on X-ray, but if there are definitely some cystic lesions, keep informed to parents that sometimes these may burst and then child may have a pneumothorax, but otherwise we should try to avoid over-treating the shadows and counts. So possibility of unusual organism, that is also important. An unusual organism in our country is Mycobacterium tuberculosis. Other is viral agents. Now I am sure that you people also may be seeing lots and lots of adenovirus, which is continuing, and PIBO is the diagnosis, and then lots of treatment is being given. And then atypical agents. This thing that more signs than symptoms, history of purulent conjunctivitis. If it is an infant, say 3-4 month old, at day 7 there was a conjunctivitis, and more in the lower lobes and interstitial shadows on X-ray. And then gram-negative bacilli, fungus, and pneumocystis jirovecii, specifically if there is immune deficiency, and drug-resistant organism, a small proportion. Received antimicrobial in recent past and local epidemiology. So if you see in your community, if you are seeing children coming with the staphylococcal pneumonia and they are MRSA, then clinical phenotype with X-ray, you are justified in giving a second line depending on the severity of disease. But if you are seeing MSSA, then possibly no point of giving a vancomycin to all the patients. So let us see this patient. This 12-year-old boy, fever for 5 days, cough for 5 days, and difficulty in breathing for 3 days. And he has a tachycardia, tachypnea, hypoxia, and chest syndrome, significant chest syndrome, and there are bilateral crepitations. And you can see he was admitted in our ICU, and the diagnosis of ARDS was made because he fulfilled the case definition of ARDS. Treatment, he was started on ceftriaxone oxygen inhalation IV fluids, and he showed a progressive worsening over 2 days and required non-invasive ventilation. X-ray, you can see dense consolidation, and then though I cover ICU as well as pulmonary, but primarily it was looked after by our ICU team. They said that, sir, there is a patient and who is not responding. So I went there and I saw carefully that there are, you can see also here, there are some miliary shadows. So I said that possibly we should investigate him for miliary tuberculosis. It may be a disseminated TB, and send the sample. So it was positive, CB0 was positive, and ATT was started, and then subsequently he developed multiple other issues, including a pneumothorax, and treated, improved. So keep a strong possibility that it may be a tuberculosis, but not all shadows are tuberculosis, and don't treat all of them with the anti-TB drugs. So this 18-month from Mumbai, though he is resident of Gorakhpur, father works in, so he was getting treatment there, and diagnosed pneumonia, multiple antibiotics, and having a tachypnea, tachycardia, suprasternal indrawing, and there is a hypoxia with chest bilateral crepitations. There was no improvement, and this was the X-ray. You can see hyperinflation as indicated by flattening of the dome of diaphragm, and there is a peribronchial thickening in the X-ray in the bilateral upper lobes. And he was investigated even in Mumbai. That sweat chloride was done at our place, but stool showed some fat globules. His the mutation was also carried out. Gastric aspirate and gene expert for gene expert was negative. GR scan was negative. HIV was non-reactive. Bronchoscopy was normal. but bronchiolitis lavage showed a human metapneumovirus, and total IG was slightly on the higher side. And he was carrying the CT scan. You can see here, this is the mediastinal, when you see the mediastinal structure, and here some are very black, some are white, some are black, some are white. It suggests that it is a small airway disease. And those who are dealing with these children with the adenovirus bronchiolitis obliterans, so it is a small airway disease due to viral infection. And it may continue for a period of, say, if it is going on for more than 6 weeks, think of this bronchiolitis obliterans. So, treated with supportive care, and he is now okay. He is now a 5-year-old. So, viral sequelae to the post-viral infection in form of a bronchiolitis obliterans is increasingly recognized. So, if a child is not responding, not recovering completely with hyperinflation, think of this condition. Then underlying disease. It may be multiple infection, severe infection, prolonged duration, unusual organism, longer duration resistant organism, think of primary immune deficiency. Family history of this thing, steroids, chemotherapy, and then if there is a malabsorption, think of cystic fibrosis. If there is a persistent wet cough from neonatal period, or a newborn which was diagnosed as a TTNB, transient tachypnea of newborn, and subsequently having a chronic respiratory problem, think of primary ciliary dyskinesia, and then there may be a malformations. Then had child developed a complication, look for pleural effusion, lung abscess, and infection at the other side of the body. So they see this patient, this 10-month-old, twice pneumonia, had oral thrush, diarrhea, and had a cone sepsis. Then obviously with these things, twice pneumonia and cone sepsis and oral thrush, then multiple sites, severe infection requiring hospitalization. So he was investigated for primary immune deficiency. And nowadays, if you have a possibility of getting a clinical exome sequencing, that is fine. But otherwise, phenotypic investigations in form of immunoglobulin, CD4, CD8 count, HIV. And then in those days when we saw this patient, it was a nitroblue tetrazolium test, which is a screening test for CGD, chronic granulomatous disease. Now we have advanced investigation. So I have taken this because even if you do not have advanced investigation, may rely on the other available investigation, or these can be developed with low cost. So his this thing NBT cells were 20% and mother was carrier because it was 70%. If then a final diagnosis of chronic granulomatous disease was made, and you can see this was a necrotizing pneumonia, hyperinflation, all those things. So a child who is having a dysphagia with recurrent pneumonia, and this is the X-ray, obviously you will consider whether it is a lymph node. But lymph node would be in the middle mediastinum or anterior mediastinum. But if you are able to separate it from the heart contour, then it is more likely to be in the posterior mediastinum or lower down. So this child had a lateral X-ray, and this was a cyst which was compressing on the esophagus, and that was responsible for repeated aspiration. And you can see there is a barium is showing a impression, and there is a CT scan showed that it was a cyst, and then he required a surgery. So this case suggests that if there is a history of feeding difficulty, aspirations, think of some surgical cause also, and do not hesitate. If he is not responding, get a imaging in form of a CT scan and bronchoscopy. So this 14-month-old resident of Delhi, persistent spasmodic cough and wheezing for 2 months, reduced breath sound on right side, not gaining weight, and history of rectal prolapse. Consanguinity is positive, but no sibling death. And there was a collapse consolidation, you can see here. TB workup was negative, but there was a gastroesophageal reflux positive. So started on amoxiclav, inhalation, anti-reflux measures, but there was no improvement in 2 weeks. And bronchoscopy was done, and which showed a thick viscid secretions. And then there was some improvement after that. But because there was a thick viscid secretion difficult to clear, a possibility of cystic fibrosis was considered, and a sweat chloride was done, which was high. So a child with persistent cough, collapse, pseudomonas from the airway and rectal prolapse, it may be CF. So this is probably the last case. 10-year-old resident of UP presented with history of respiratory distress, diagnosed with as a TTNB at birth, and wet cough since age of 1 month, nasal discharge, ear problem, 1 episode of hemoptysis recently, consanguinity plus, no sibling death. Clubbing is there, mild pH, and she received multiple courses of antibiotic, 3 courses of anti-TB drugs. And you can see there is a collapse of the left lower lobe with diffuse lesions, and CT scan confirmed that this is a bronchiectasis. Collapse along with bronchiectasis. How you make a diagnosis of bronchiectasis on CT scan? You see this is the airway, along with that there is a vessel. So if airways are larger than the vessel, then it is a bronchiectasis. Generally, vessels or vascular component is bigger than the airways. So if it gets reversed, then it is a bronchiectasis. So because of hemoptysis, it was found that there is a abnormal bronchial artery which was responsible for it. So a possibility of PCD was primary ciliary dyskinesia was considered because of persistent wet cough, nasal discharge, ear problem, and so this is a screening test, which is nasal NO is a screening test. If it works, no. So this is, you might be doing a FeNO, that is for the asthma, children with asthma, which is increased. But if it is a nasal NO, it is decreased in primary ciliary dyskinesia and is considered as one of the screening tests. So nasal breath for high-speed video microscopy was done, and there was an immortality of cilia. I'll show if video works, because that we have developed an innovative method of on the site making a diagnosis of primary ciliary dyskinesia. EM you can see here all distorted, and diagnosis was PCD was made. I'll see if it works. Anyway, these are these breast, we take a breast sample from the nostril because airway epithelia is same. So it is easier to take a sample from the inferior turbinate, put it under the light microscope, use your either iPhone or some camera which has increase the frequency of taking the picture. And then you can document that these this is the immotile, and this it is not working anyway, but it is you can do it in your hospital or with the help of your lab people. So what should be our approach? See whether it is some mimicker and not a pneumonia. Then think of those other conditions including anemia, acidosis, heart disease. Check whether the child is getting appropriate antibiotic, appropriate doses, and route of administration. Then think of unusual organism, drug-resistant organism, underlying illness like immune deficiency which is emerging, malformations, of course cystic fibrosis and primary ciliary dyskinesia. If a child is not behaving as it was expected, that it should recover or coming repeatedly. Common causes are inappropriate antimicrobial dosage, duration, aspiration, and these other respiratory problems. Good history and examination gives important clue for underlying illness. Investigations are these which I had shown you, and management as per the underlying cause. Thank you very much.
Thank you very much. I think sir has delivered his lifetime experiences, and experience is the best teacher, I think. So lentil hypersensitivity is one of the causes for prolonged pneumonia, lentil hypersensitivity. Then post-pneumotic emphysematous bully, if we confuse with this staphylococcal infection, then clinically the patient is improving, then we need not worry. Then incidence of post-pneumotic bronchiolitis obliterans is increasing. Probably these are the points we learnt new. And one more thing, we staying in a small city, probably few of investigations may not be available in resource restricted setting. But definitely because of this thing, we learnt lot of things about managing difficult pneumonia. Thank you very much, sir, for your excellent presentation and adding to our knowledge. Thank you very much.
Thank you, sir. Thank you, both the chairperson. I request both all the three dignitaries to proceed to the felicitation area. A small announcement. Tomorrow we shall commence our session at 8 a.m. with paper and poster presentations for postgraduate students in the Mawa Hall. So.